Hey there, future nurses. Let's take a few minutes to simplify something you'll see all the time in clinical practice: antihypertensive medications. Whether you're passing meds, monitoring blood pressure, or educating patients, understanding how these drugs work is essential. Let's break it down together the easy, natural way. Let's start with ACE inhibitors. These drugs end in april. Think lisinopril or enalapril. They work by blocking an enzyme that converts angiotensin I to angiotensin II. Why does that matter? Because angiotensin II causes blood vessels to constrict and tells the body to hang on to sodium and water. Block it, and you get vasodilation and lower blood pressure. Here's a great way to remember the common side effects of ACE inhibitors. ACE, angioedema, swelling of the face, lips, or throat. This is dangerous. C, cough, usually dry and persistent. This one's common, not dangerous. E, elevated potassium, can be dangerous, so we need to monitor labs. Next up, ARBs, angiotensin II receptor blockers. These end in sartan, like losartan or valsartan. They work a little differently. Instead of blocking the formation of angiotensin II, they block the receptor sites where angiotensin II tries to attach, so you still get lower blood pressure, but without the dry cough that ACE inhibitors often cause. They're usually given to patients who can't tolerate ACE inhibitors. Think ARBs are chill, no cough, no drama. Beta blockers, LOL drugs. These all end in holol, like metoprolol or atenolol. They block beta-1 receptors, which are part of the sympathetic nervous system. That means they slow the heart rate, reduce contractility, and lower blood pressure. But here's what you need to watch for: bradycardia and heart blocks. Breathing issues, especially in people with asthma, can mask signs of low blood sugar, so diabetics need to be careful. Not great for heart failure patients in acute stages. Beta blockers equals be cautious. Calcium channel blockers, very nice drugs. They relax the heart and the blood vessels by blocking calcium from entering cells, which reduces how hard the heart has to work and increases oxygen delivery. They're great for lowering blood pressure, treating chest pain, slowing the heart rate. Use this mnemonic: VND, very nice drugs. V, verapamil, and nifedipine. D, diltiazem. Just keep in mind, they can interact with digoxin, and they also lower HRMBP, so always monitor both. Diuretics, often paired with antihypertensives. They help get rid of excess fluid, reducing blood pressure, but they can also deplete important electrolytes like sodium and potassium, especially loop and thiazide diuretics. Nursing considerations. What you need to know: always monitor blood pressure and watch for hypotension. Teach patients to change positions slowly to avoid dizziness. Keep an eye on electrolyte levels, especially potassium and sodium. Educate patients to report symptoms like muscle cramps, weakness, fast heartbeat, dizziness. Watch for angioedema. Swelling of the face or throat is a medical emergency. Important tip: patients should never stop antihypertensive meds abruptly. It can cause rebound hypertension. Meds need to be tapered safely. Quick recap: ACE inhibitors equals pril, watch for cough and angioedema. ARBs equals sartan, no cough. Beta blockers equals olol, slows HR, masks hypoglycemia. Calcium channel blockers equals VND, relax heart and vessels. Diuretics equals ditch the fluid, but monitor those electrolytes. Alright, you did it. Understanding antihypertensives can feel overwhelming at first, but with the right memory tools and clinical awareness, you'll be ready to explain, administer, and educate with confidence. Thanks for tuning in, and keep learning, one beat at a time.